Welcome everyone, this is episode number 15. My guest today is Dr. Lydia Temoshok. She's an internationally respected researcher, author, and editor in the overlapping fields of psycho-oncology, biobehavioral neuroscience, psychoneuroimmunology, and behavioral medicine. As a young assistant professor at the University of California, San Francisco School of Medicine, she established and directed the first research consultation program in clinical health psychology and psycho-oncology in the UCSF's Malignant Melanoma Clinic, as well as the first behavioral medicine clinic within the Division of General Internal Medicine, where early on she recognized the importance of what would be called AIDS as a new disease and emerging epidemic. In addition to her research, Dr. Lydia Temoshok provided strategic consultation and leadership to the National Institutes of Health, the Centers for Disease Control and Prevention, the World Health Organization, the United Nations Program on HIV/AIDS, and the U.S. military's HIV/AIDS research program. As professor of medicine in the renowned Institute of Human Virology at the University of Maryland, Baltimore School of Medicine, she developed and directed a multidisciplinary clinical research program on HIV behavioral prevention and led NIH-awarded research on elucidating the biopsychosocial mediators of HIV progression. The author of over 200 articles on biopsychosocial aspects of cancer and HIV/AIDS, she has authored and edited 12 books, including The Type C Connection, The Behavioral Links to Cancer and Your Health. She is currently writing a book tentatively entitled Deception, Doing It, Detecting It, and Dealing with It, focused on scientific deception, misconduct, and misinformation. A licensed clinical psychologist, Dr. Lydia Temoshok provides counseling to help enhance coping with the mental health sequel of cancer, HIV, and the COVID-19 crisis. Dr. Lydia Temoshok is a summa cum laude graduate of Yale College, where she was in the first small cohort of women admitted. She received her MA and PhD in both clinical and social psychology from the University of Michigan, Ann Arbor. In this podcast, Lydia talks to us about repression, what happens when we push information in the unconscious to reduce pain and distress and leave space for what she calls a precarious balance, and the price we pay for the state of uneasy poise and false sense of calmness. This is an incredible interview, and I'll tell you why. She's so articulated and makes scientific evidence so palatable, and she's funny. I remember teaching in my classes this idea of just how powerful and dangerous it can be for us to try to solve problems based on conscious reasoning, all the while our biological core harbors unconscious knowledge and experience and wisdom that says otherwise. Lydia talks about this in this podcast, but in a very simple, palatable way. She's a phenomenal knowledge translator, in my view, and I feel so privileged and honored to have had an opportunity to meet her and learn from her firsthand. She also talks about the importance of forgiveness in healing, not pardoning, but release from holding a grievance, and the scientific findings around this work that she has conducted. Lydia will be talking to us also about the Type C maladaptive learning coping behaviors, which are deviations from homeostasis, or a balanced state of being physiologically and mentally at peace, and how, when we fail to recognize, respond appropriately to, and resolve stresses, thus keeping our physiological stress response chronically engaged, we end up with long-term damage to the biological systems where these patterns are encoded. Please join me in welcoming Dr. Lydia Temoshok. Lydia, welcome to the show. I'm so delighted to have you on the show today and have the opportunity to learn from you directly. I knew you since the time I used to teach at the University of Toronto, an insane number of courses, and I came upon your work and I was blown away by it. So welcome to the show.
I'm so delighted to be here talking with you. Thank you for the opportunity.
I'm going to start by asking you, what was the impetus behind the research work that you have been doing? How did it all start for you?
Well, there are really distant impetuses, such as I was always looking and observing people in my family. I had an aunt who developed cancer, and she seemed to get cancer a lot, breast cancer. I was very unfortunate. And I was wondering, well, why is that? And so I started to ask questions, even as a little girl, about that. But I didn't have any theories then. I was just saying, okay, this is interesting. Not everybody gets cancer. Why does she get it? What's going on here? And she was an unhappy person when her husband would leave town. And I noted that. And I noted things like that. But the near impetus was, I was at the University of California, San Francisco in 1978. And I was a new assistant professor, and I was in a stress center. And that was going okay, but stress was not my main thing. They were studying at that point at the center the Jonestown episode, what was going on there, and that was certainly stressful. But that was not. It didn't strike me. But there was a professor of oncology in the malignant melanoma clinic, Dr. Richard Sagebiel, who contacted the head of the stress center, Dr. Marty Horowitz, and said, hey, do you have anybody there who might be interested in looking at, why we have some patients with malignant melanoma who have really good prognosis, but they do poorly. And then there are other patients who have really poor prognosis, but they do really well. And we think it's related to stress. And he said, well, I know Lydia's been expressing some interest in the health field, so maybe she can talk to you. So that was the impetus. So I went over to the malignant melanoma clinic. It was across the street, and it was a tertiary care clinic. And I didn't know anything about malignant melanoma. I started looking it up, and I said, well, the first thing I need to do is to talk to people, because that's my understanding of the best way to observe and to get information about what might be going on. So I started to talk with people, and I had come in at that time also reading in behavioral medicine, which was a brand new field at that time, the work of Rosamond and Friedman, who had written about the type A behavior pattern.
Yes.
And they had an interview that they said it's not just the content of the interview, it's the way that people answer when they're asked questions. And it's a behavior pattern, the type A behavior pattern, that seems to be connected with cardiac disease, all sorts of other heart disease problems. And they had some good research about this. And they had started by observing that the patients in their clinic seemed to be sitting on the edges of their chairs. The reason for that is that an upholsterer had mentioned to Rosamond and Friedman that why is it that the edges of your sofas are all worn down? Well, it was because the type A people were sitting on the edge and bouncing up and down.
Wow.
And so I said, okay, I got to start somewhere. I think there's maybe something going on here. Let me ask the same questions that they asked in their type A interview to these malignant melanoma patients. Dr. Sagebiel gave me access to the people, and they were more than happy to talk with me. And they were very generous with their time, and I talked with them and I asked some of the questions. And the questions in the type A interview were things like, do you ever play games with your children? And the people say no or yes, and no matter what they say, the interviewer is supposed to respond a little harshly and say, well, why or why not? And do you let them win? Why or why not? And another question is, what do you do if there's somebody following very close to you on a windy road? He's close behind you and it's kind of dangerous. What do you do? And the type A person would say things like, well, before the question even got out of the interviewer's mouth, the type A person would say, well, I would, honk my horn. I would put on my brakes. I would indicate that this is really bad behavior. And so I started to ask some of these same questions. And it was striking to me that the people who I was interviewing didn't have any type A responses. They had almost the opposite. So that one of the questions is, how often do you get angry? And again, in the Roseman and Friedman interviews, the type A person would say, well, all the time. I mean, your receptionist wasn't even ready for me. And I was coming up the elevator and I was pushing the button again and again, and I couldn't do it. And so I was asking this question to the malignant melanoma patients, and they would say, angry? I don't know. I can't remember a time when I've ever been angry. And I would say, well, how about annoyed or irritated? And I remember one response, the person said, well, there was this time when somebody ran into me. I was at a stop sign and they kept on going. And I was very irritated that this person, first of all, ran into me and then left. It did upset me. And then to the question of what would you do if you're behind somebody and they're going much too slowly? Again, the type A person wants to get around them and then honking the horn and everything. The cancer patient would say, well, there must be a reason why that person is going slowly. They must not know the road. I would pull over and just give them some time or space to do their thing. I go, wow, this is very interesting. So I began to ask this interview of more and more patients in the clinic. That's how I got started on that, and seeing that there was a pattern that was emerging. And fairly soon, my colleague, who was also bouncing ideas back off and on with, was Bruce Heller, and decided to call it the type C behavior pattern. And again, there's some misconception, when people refer to type C, they call it personality. I don't know. Roseman and Friedman always called it the type A behavior pattern. And so I wanted to call it the type C behavior pattern, but nobody ever wanted to call it that. But I began to think of it more as a way of coping with stress, because I would hear about their stories. And then I would also ask them questions about their lives. Had they ever experienced anything like this before? And that is a cancer diagnosis of a serious disease. I mean, malignant melanoma is one of the most serious types of cancer, and some of them had very thick lesions. The more invasive the lesion, the thicker the lesion, the worse the prognosis.
Quite prevalent. So Lydia, describe to our listeners, if you may, this maladaptive type C coping style. What is it?
All coping is an attempt to relate to our environment, to adapt to it, to deal with stressors. And so all coping starts off, you're a little kid, you're trying to adapt to your environment, you're trying to do things, and survival is the number one thing. And then there's psychological survival, and then there's being happy and all sorts of other higher order of things. But survival is one of those things. The type C coper in later life, I found in a lot of my interviews, may have started off as an abused child, or having someone give them very poor feedback about things, so that a child might say, I'm hungry, and the mother would say, no, you're not hungry. No, you just ate, so you can't be hungry. And dinner is at 7 o'clock. You just wait. Or for a case of abuse, the child might say, "This is terrible. I don't like this." No, this is good. We don't want to talk about anything that's negative. So the child learns to survive. He's looking to the parents. She's looking to the parents for, how do I do this? I've got to grow up in this household. How do I do it? And begins to push down negative feelings. Yeah. So I don't feel hungry. No, I don't feel sad. No, I don't feel pain. No, I don't feel afraid. I don't feel any of those things. I'm fine. And then they get rewarded. Good little girl, boy, and they go on from there. So the type C person, coper, is trying to survive and trying to cope by pleasing others in the environment, people who are important, who hold valuable resources, parents, and then later on it's a job or a spouse, and so on. And you're trying to please people. Nobody really likes angry people, and so they learn to suppress the anger. And there's I wouldn't say controversy, but there's a conceptual discussion about what is repression, what is suppression. At some level, emotions get so suppressed, I believe, in the type C person, that they become subconscious. So you're not aware of them, which is different from suppression. Suppression, it says, I feel angry, I'm going to suppress that because it's not good to express it. But repression is, I don't feel it. I can't do that. So, and that goes for other things that are seen as maybe not good, like needs. Oh, I have a need. I'd like somebody to help me with something. No, you don't need any help. You're a big girl. You can do that yourself. Or I don't have time right now. Later. So I think that's how it develops, and it starts off as an adaptive coping, and then later on in life, as long as things are going well, you're okay. Relatively. It's precarious though, because life is going to hit you with stuff. That's sooner or later something is going to happen.
It comes for everybody. Yeah,
it's going to happen. And then what happens? Are you going to express your needs? A parent gets sick and you're scared about that. You have a need to talk about that. Or if the boss asks you to work overtime for the 10th time in 2 weeks, and that's okay. Not expressing your need to go home, have a family life, do all these other things, because you believe you need to help the work situation, and the boss needs help more than you do. That was one of the other questions I asked the patients in the clinic. I said, what's the worst thing about having malignant melanoma for you? And they would again be, worst for me? Oh gosh, I don't know. I'm very concerned that I can't do what I usually do. I'm not available to drive my kids to the appointments, their appointments, or to school activities. And that's why it took me a long time to come into the clinic. I was doing all these things, and I know that it was hard on my boss at work, because if I took time off to go to an appointment, I was inconveniencing them, and someone else had to do my work. So it was really hardest on those folks.
So always concerned about the people that they were serving, my boss, my children,
exactly.
People in the outer environment,
and again,
self.
Exactly. And that's what all of their perception is focused externally, not internally. Yeah. And that leads to not recognizing that you have a problem. I mean, people talk about negative emotions. I don't think there's a negative emotion. Emotions are there to tell you that something is wrong, something is out of balance, and you need to address that. But if you don't think anything is wrong, nothing is going to be addressed. Pain is there because you need to address it. And I was interested fairly early on in this research of, well, okay, let's look at the correlations between how much someone has this type C pattern and their progression of disease. Because we couldn't study incidence. Everybody already had cancer, malignant melanoma. But the question is, again, as Dr. Segabiel said in the very beginning, some people who have a good prognosis don't do well. Why is that? And so did a series of studies and began to look at things that might be playing a role in that. First of all, we did see that the more type C you were on a scale, even though type C sounds like it's a category, it's really a dimension. And the dimension is a type C coping behavior, type C coping interpersonal style, type C coping physiological style, type C coping emotions, and so on.
Quick question for you. Would it be fair to say that they're not mutually exclusive? So in other words, is it possible for me to have some dimension of type C and have some percentage and have some percentage of type A and some percentage of type B? So we're a little bit of everything, or is it mutually exclusive? If I'm a type C, I'm a type C, period.
Oh, no, that's a very good question. And that's exactly kind of the point I was indirectly making, which is that, someone may be very predominantly type C, not only strong type C, but doesn't have anything else. So that the only thing they can do in a stressful situation is repress and suppress because they're really type C. Whereas other people might have, a little more type A, or the Roseman and Friedman called it type B, which is really just the absence of that. It's more of a, okay, yeah, you make me angry. Oh, you're making me angry. Back off, or whatever you're going to say. And the type B expresses emotion, but there are some type Cs, very strong, who don't express that. And just as one of the quick and dirty studies I did early on, looking at the type C dimensions, was to look at. I said, well, there are some people who have the epidemiologic prognostic or risk factors for melanoma. So you have blonde hair, blue eyes, and freckled skin, or red hair, freckled skin, and you're out in the sun a lot. And then that would be, and they tended to get sunburned, or they would report getting sunburned. And then there were the people who had dark hair, dark skin, and who you say, well, gee, how did they get melanoma? And then there was the question of where the melanoma was. So if the melanoma was on the arms, the exposed areas of the skin, or the person is bald, or is it on the head, or on the back because you're swimming, or and then there were some people who developed melanoma in hard to reach places. Bob Marley died of malignant melanoma on the sole of his foot. Other people who I interviewed, one lady had melanoma in her vagina.
Wow, interesting.
Another person who I had known about as an indirect acquaintance had developed malignant melanoma in her eye. Again, fairly rare. And one thing I recall thinking back is that her husband was a philanderer. And I asked him once, doesn't your wife know about this? And he said, oh, she turns a blind eye. She turns a blind eye to it. And
wow, that's telling.
And I said, well, wow. Okay, coincidence? But whatever, it was I didn't put that in any of my reports because people would criticize it and say, well, that's an anecdote, and the plural of anecdotes is not data. But I did look at the difference between people who had the melanoma prone risk factors, blonde hair, blue eyes, freckle skin, red hair, sunburned, etc., versus those who had the dark skin and the melanoma in strange places.
Mm-hmm.
Now, who do you think were the most type C in terms of their coping?
The ones with the melanomas in unusual places.
Right, the dark-haired people. Dark-haired people with our melanoma in strange places, yes.
Yeah.
So they were absolute, there was a huge difference.
Wow.
So I said, okay, so that you had a causal reason.
Yeah.
You're out in the sun, you got sunburned, you had this complexion, and it set you up for getting melanoma. And these other people didn't have anything. And melanoma is exacerbated by, immune function.
Yeah.
So, and actually one of the most immunologically related diseases, to the point where now immune treatments are really good for it, which is what Jimmy Carter got.
Yeah.
And so it made sense to speculate that the way that this coping pattern has its effect on progression is through, the immune system. I was in University of California, San Francisco, assistant professor, and that's the exact same time that AIDS was coming along.
Right.
1982, and I was one of the first people in the behavioral medicine clinic, see AIDS patients.
Yes.
And so I also thought about that, that studying people with HIV/AIDS might also be a way to get a handle on, what is, if the immune system is mediating this or affecting this or contributing to this, a contributing factor. It's not the only factor, there's genetics, there's other things. With HIV/AIDS, it's, did you encounter the virus? Were you exposed to the virus? But the idea is that the immune system in HIV/AIDS, it's not like more immunity is good. And again, early on, people had this idea, oh, your immune system is weak, you have a weakened immune system, and that's why. No, it's whether it is functional. It is working well in a balanced sort of way. If you have too much immune reaction, you get autoimmune syndromes, arthritis and other things, and that's not good either. And that if you have an immune system that can't mount a response, then that's not good either. So then I began to develop this idea of homeostasis and the ideal of the inverted U-shaped curve. Think of you, turn it upside down, and that the ideal way to respond to any stimulus that's coming along, whether it's a stressful stimulus or just some new piece of information, is to pay attention to it. You say, whoa, okay, whoa, there's something going on. Let me pay attention to this. And your physiological systems get geared up and they say, let's look at this. And then you start to rise. The physiological systems go in synchrony. You have your heart rate goes up. You go, whoa, I'm interested in that. Your pupils dilate. Oh, that's interesting. I'm going to look at this. And then you say, oh, well, it's actually not threatening. I've assessed it. I've looked at it. It's not a problem. And then you go back down again. You say, okay, let me go back. I have something else to do. And then you go back to baseline. You cannot have all of your physiological systems all the time at that high level.
Yeah.
That is not a good situation. Mm-hmm. perseverative in the mental realm and in the physiological realm, you're going to burn out. You have your heart rate always up, you're always reactive. And in the case of HIV, an activated immune system is what synergizes HIV replication. So, and now we're seeing in the later years how much inflammation is a problem.
Yeah. And it's a huge problem.
It's a huge problem. I mean, almost any disease you mentioned
is linked with inflammation. Yes.
COVID, you have multi-systemic immune activation system syndrome. And so that was one of the things I started to theorize. It's not just it's larger than type C coping. It's across the board. What is the appropriate response to a stimulus? The stimulus might be a mental stimulus, or it could be a physical stimulus. It could be, a virus coming along. You want to respond to the virus in an appropriate way. I guess the word appropriate is the one I started to use a lot. You want to respond. You don't, if somebody knocks at your door, you don't go, oh my God, it could be something. And then you panic and you do that. No, you respond appropriately. And then you go to the door and you see it's just of a mail carrier and he's got, the mail or whatever. Then your system goes down. But if you're always activated, you're just going to be at that level. And the one study that I did actually showed some of this with the spiritual dimension, which was forgiveness.
Oh my goodness, tell me about that. This is very interesting.
The John Templeton Foundation is a very interesting foundation. They like to look at values and spiritual concepts and difficult concepts, and they say, well, how do these affect things? How do these affect life? And one of the things they looked at was, how does forgiveness operate in the world? And I said, well, I think forgiveness is going to affect health, because I saw the results of people not forgiving. I mean, a lot of the patients I would interview, they carried along this resentment. They would say, oh, I forgive you. Again, the type C person would be, I forgive you, because that's the thing to do. They're going to church and Jesus says you forgive and you all forgive, and they're doing what everyone wants them to do. But meanwhile, they are thinking about, oh gosh, he did that to me, or I was so nice to her, and yet this is how she repays me. She does this. She steals my husband. And
it's important to define here or to differentiate between forgiveness as pardoning someone for something they've done, and here you are, a noble character, you're going to pardon them because it's better to forgive than to carry a grudge, versus forgiveness in letting go of the resentment. And that's what you're talking about.
Yes, exactly.
And that may or may not entail pardoning. You might just say, no, what happened was bad, but I'm not going to carry on this resentment, this grievance with me, because it's like drinking poison and expecting somebody else to die from it.
Exactly. And that was, and we studied that with HIV, and we saw
fascinating. And what did you find, Lydia?
Well, I found a couple of things. First of all, we looked at a number of physiological measures, a lot of the same ones that I had used with cancer patients. So heart rate, and electrodermal response, skin response, and skin temperature and other things, and try to see, how much, when they're talking about an incident where someone had done them wrong, how much are they engaging in this physiological reaction. Now, that's not appropriate. You're in an interview with somebody, you're telling someone about an incident of forgiveness, and your heart rate is up. Ooh, that's not good. Imagine how often during the day that happens. Something triggers that memory of being wronged and you have that response. That's not good. If you're an HIV patient, that's activating your immune system, because we saw a very strong link between physiological reactivity at the autonomic level and these prognostic indicators in HIV, which had to do with immune function, so that IL-6, which is a pro-inflammatory cytokine, it gets that inflammatory response going. Those were up during that period of time, and we had a whole experimental protocol where we could actually show that. Why did I study HIV instead of cancer? Well, it was easier. I was at the Institute of Human Virology. I had immunology colleagues. There was a lot of research going on with HIV, and I said, well, it's the same idea as with cancer, but it's the appropriateness, the adaptiveness of the response that matters. And if you are overactivated and you don't return to baseline, that's the problem.
Question for you: good stress, bad stress. There has been quite a bit of talk about this, and so the idea of good stress being, well, when your body kind of gets activated, it's the body's way to saying, pay attention, this is important for you, you need to attend to this task. But there is a difference between that and the bad stress that we're talking about. That's exactly what you found with the HIV patients: activation that stays up and continues to stay up even when it's not appropriate. And again, key here is the word, how appropriate is this response for the length of time that it manifests. And
well, I think stress is not good or bad per se, although some things you say, yeah, it's never good when someone dies. It's never good. You're always going to be stressed when you're moving. That's always going to be a problem. Now, the question is how much you are overwhelmed by that. Right. So that if you can handle it, you can say, well, I don't like to move. It's not great stress, but I can get through it. I'm gonna be active. I'm gonna lift those boxes. And if you're appropriately going to ask friends for help, and if I have a friend who has a T-shirt saying, "Yes, I have a truck. No, I won't help you move." And so he's very appropriate in terms of not wanting to get stressed out by moving.
Yeah.
The type C person, though, will sacrifice anything.
Absolutely.
The strong type C. Will say,
my entire family, everybody. Nothing matters except you right now. Let me serve you.
Let me do this for you. So again, what is overwhelming stress? It's never good. These people in floods, all these wildfires, all these horrible situations, that's always going to be overwhelming. But there's certain more or less everyday stresses. How much can the person handle that? And what becomes maybe stimulating? I like to do lots of things at once.
So do I. At the same time, with balance. I do, I swim really hard, but I know there is an island in sight, and that I will rest on that island, and I will find whatever is needed for me to do that.
How appropriate. That's great.
How appropriate. Question for you, Lydia.
Yes.
Is this relationship that you found between type C and maladaptive coping style and melanoma restricted to melanoma, or have you conducted other studies, or have others conducted other studies and found this relationship holding to other types of cancer? My assumption would be that it will hold, especially based on your HIV studies, but I'd like to ask you.
Yes, and I think it's a question of degree, and it's also a question of what measures you're using.
Right.
So if you can't use typical questionnaire measures. Because if you ask somebody, how often do you find yourself getting angry, but you suppress that emotion? Because a type C person will never admit to that. The type C
100%.
person
Yeah.
will never say, oh, yes, I get angry. First of all, they will say they get angry, and they will never say that they suppress or repress, because that sounds negative, and they always want to present themselves as looking good. So any of the studies that have been done in other cancers that looked at, that used these typical questionnaires, they might not have found it. And I actually had a discussion with somebody in Lancet about this, where she said, "Oh, we have disproven the type C construct, because we looked at it and we didn't find it in these other patients, other cancer patients." Well, first of all, there are other kinds of cancers. Secondly, they you ask these questionnaire things as opposed to look at other distinctions, the difference between someone's, I conducted lots of studies, looking at someone's emotional expression. Is it genuine?
Beautiful.
Paul Ekman has done a large number of
Yes, he
studies.
did. Yes.
And I taught with him and worked with him in San Francisco, and we course in emotion, and I was very struck by, and used his emotion coding system to say with the melanoma patients, coding the part of the videotaped interview that I had, saying, are they authentic in their expression? So again, I would say, how much were you upset by having malignant melanoma? And they would say, oh, it was fine, actually. It was a blessing in disguise. There was a silver lining, and they would be cheerful. And then you looked at it in terms of slow motion, and they're going, they're showing a pain face or some other kind of face. It's not a joy face.
Yeah. Wasn't it Thayer in the 1970s? And he's done a lot of physiological studies on arousal. And wasn't he the one that said, listen, the best way to look at activation is using both physiological measures, but also subjective measures and questionnaires and so on, or interviews, behavioral assessments and so on. Really, that's the most balanced one. So thinking back to the conversation you had with your colleague about the Lancet, study, I think that would be quite relevant to the argument that it's all about measurement. It depends on, not all constructs have a preferred single measure to assess it. I mean, behavior is so complex. Human psychology and physiology is so complex. To think that one measure alone will cut it, that's quite naive.
It's very naive. And I developed a technique, not necessarily a measure, but a technique that I used with melanoma patients, trying to get at the type C, trying to get them to admit to this. And I developed, it's called the Vignettes similarity rating system. So you have a vignette, and it's about a person. It's a story, a little story about a person who hears that they've been diagnosed with cancer. You can make up the story about anything. Yeah. And then you have a person acting, behaving, emoting, and relating in a type C kind of way, or in a type A kind of way, or in an appropriate kind of way. So that with the type C, it's, Jane was diagnosed with malignant melanoma. She had some questions for the doctor, but the doctor, she's sure, is very busy, so she wasn't going to ask some more questions about it. She's sure it's going to be okay. Besides that, there was a lot going on in her life, and she needed to do these other things. So you have the vignette very balanced, so you're not stigmatizing the person, but the person sounds like a great person, And then you say, how much are you similar to Jane on a scale of 1 to 10? So they're not talking about themselves. It's a rating of how much are you similar to this person. So it discombobulates the usual favorableness ratings that we all have. You want to look good on those scales. And then, but I used it for other things too, because people who would never admit depression, you have a depression technique, an depression vignette where you're saying, Joe was really feeling that why should he bother? Mm-hmm. He looked at the TV and the news is always bad, and in fact, why have the TV on at all? So he found himself withdrawing from things. And how much are you like Joe? Scale of, you have a few more things to flesh it out, of course. And people who denied on one of those scales that they were depressed, it said, that's exactly like me. I'm exactly like Joe. And they would admit to this. So I use this technique a lot.
Yeah, it's brilliant. It's brilliant. What a great way to inadvertently get to a pattern of behavior and making it more socially desirable, if you may. Because I'm just like, again, everybody likes me. I'm just like so-and-so. It's easier to admit in that context than it is to admit if asked directly.
And I'll tell you another anecdote, which again was not in my published papers because people think anecdotes are not scientific. But my mentor in a lot of things, Dr. Bernard Fox, who died in 2001, he was a great epidemiologist. He was the first person who questioned David Spiegel's studies in terms of their epidemiological
soundness.
Soundness. He did a good study in terms of a random clinical trial. However, the people who received the treatment did not necessarily get any better than the standard patients who had cancer in Northern California. It was the control group who happened to have been, by chance, allocated to the control group. And because it was a small group, which is what you're not supposed to do in clinical trials, you're supposed to have enough of a group, they did significantly worse than the standard patients. So it's not like the treatment made a difference. Anyway, I really appreciated Dr. Fox, and he appreciated me because I was trying to do the scientific stuff, and he was always questioning these other studies. I'm not sure it relates to outcome. I'm not sure. He's questioning all these other folks, and so he said, "Okay, we're gonna do a study of the people in the Western Collaborative Group study, which were the people who were doing heart disease. Many years ago, they had the videotaped interviews, the Freeman and Roseman type interviews, and they said the people who were reanalyzing this data said, okay, Temoshok and Fox, you think you're so smart about type C. Well, some of the people who we had interviewed didn't develop heart disease, they developed cancer. And I wonder if you could pick them out. We're going to give you 25 interviews on tape, and why don't you listen to them? And why don't you tell us which ones developed cancer and which ones didn't? You don't have to say whether they developed heart disease, but just say, did they develop cancer or was it something else? So Bernie Fox was applying he was a very methodical person, very statistical, and he was applying the type C criteria to those interviews. And he had his projections. I listened to the interviews. And I decided to be dramatic. I came into the room and I said, I don't know what other people in this stack of interviews developed cancer, but I know that number 14 got malignant melanoma. Number 14, malignant melanoma. because I had seen clearly in the interview the malignant melanoma pattern. So you had asked, this is all in response to your question about other cancers. And they said, oh, they looked at it and said, she's right. 14 died of malignant melanoma.
Yeah.
And that was because, I mean, it's not woo-woo, psychic stuff. It's that I had seen the pattern.
There was a pattern.
This is how they developed. Now, maybe if I had interviewed a whole lot of breast cancer patients, although I think breast cancer is so mixed, there's so many genetic factors, there's so many other factors going on, that it's not going to be as strong as the immunological aspect of malignant melanoma. But there have been people who have duplicated this. About a lot more research in Europe. But the type C pattern is not good for anything. It's not good. It's not good. So it has to do with vulnerabilities and other things. So anyway, that's a long answer to your question.
Two things. Number one, isn't it ironic of how quickly we get criticized by using stories and cases, and they get dismissed as anecdotes? Yet, if we want to do a good job in terms of knowledge translation, we do have to have narrative. In fact, that's how you communicate with the lay people. Otherwise, you get stuck in the academic jargon, and this information never gets translated to the public. That's why I love this milieu of a podcast where we get to talk like two normal people. We're two women, and I'm fascinated by your research. I think it's wonderful. It has so much potential. I think it needs so much light shed on it, and so much of it could be integrated in the context of what I do, for example, looking at the quality of life of men diagnosed with prostate cancer, this whole issue of vulnerability and type C. Oh my goodness, this is definitely an avenue to pursue. So I find that ironic. Number two, I have a question for you.
Yes.
So Lydia, from your own observation and research and talking to others who have done research in this area and on type C in particular, are some people more prone to it than others? Are males or females more prone than each other? Or, a certain social economic status? Are there any particular characteristics that when combined, may lead to the co-occurrence of those characteristics and type C coping style?
Well, again, I have to go back to the melanoma situation, that there were men and women who had it, and pretty much in equal numbers. And in fact, number 14 in that series was a man. People say, well, but aren't a lot of the type C characteristics that you've described, aren't they describing the woman, the traditional role of the woman, and what she does? Well, this particular person was a man. He was, or they say, or somebody who's at a low level at work. Well, he was the principal of a school. And one of the questions on the type A interview was, do you often take work home with you? And the type A person says, damn straight you do. I have to get ahead. It's a dog-eat-dog kind of world. To get ahead, you need to take work home. Or other, you might have some other response. But this principal said, I said, oh, yeah, I do. My colleagues think I'm really good at getting everything together, but I do struggle with it, and I don't want to disappoint them, and I have to take work home in order to do the best job possible. So I end up doing that every weekend. I spend a lot of time. I said, type C, malignant melanoma. I mean, that was what did it for him.
Yeah.
So, but again, melanoma mostly affects white people, and people with the fair skin, and so on and so forth. So it was hard for me to see that, but certainly you have these early experiences where you have to look to your environment. Like I said, abuse. I think with the abused child is looking around saying, okay, what what does daddy want me? How perfect does he want me to be so that he's not angry at me? And whether it's girl or boy. And I think that in the case of African Americans, they have a culture where they have to look out, they have to look around, because there are all sorts of people who may be prone to think the worst of them, and they have to say, well, what does this placement want? I mean, is my license on straight? Do I have a something dangling from my mirror that they may stop? Am I turning on my turn signal? Oh, and they, so that leads somebody to be really aware of the environment, because you have to be aware. You have to be aware that there are people out there who do not wish you well, and who could hurt you. So, and then just unfortunately, there's an increase in violence against Asian Americans now, and so Asian Americans have to look at that. But that's not an individual thing. It's a cultural thing. But you have a whole group of people. Well, on every dimension you could possibly look at in terms of health, African Americans do worse, and that's and it's probably because they have to be looking out, and there's also access and all sorts of other factors. But one of the things is you have to look out. You have to be watching yourself at all times.
Yeah.
How do you interrupt that series of events, that series of life events, so that one can, begin to react in a different way that's maybe better for your health? How do you begin to say that something is wrong? How do you begin to express yourself?
Mm-hmm.
And that's the thing I've struggled with in terms of designing interventions, or talking with the many patients with malignant melanoma and also HIV/AIDS. How do you suggest that they kind of look at that pattern? Because you have to say at the very beginning, look, this pattern has served you well in some capacities, but it's not serving you well in terms of this. And they have to understand that. They have, or they might say, I'm not doing well. I'm not doing well in this, or my health is not doing well. They have to have a reason to come in and see you, to want to change it. You can't just say, oh, well, you're type C, you need to change. No, they have to have a reason. And then you can say, well, let's look at this. Let's look at, what you could do differently. And one of the main things I suggest is how communication to others, because that's a great place to start. So communicating with your doctor that something is wrong. You need to talk about all of the problems. You can't just say, oh, that's I have an STD. I'm not going to talk about that with the doctor, because that's a no. Mm-hmm. No, but to be forthright. How can you do that in a way that you're comfortable with sharing that? Or if you need something from a spouse or partner, or you're even assessing your situation. We have this kind of cultural phenomena that during the pandemic, everybody's quitting their job. Well, they're quitting their job because they've had time to think. They've had time to be mindful and go, man, that was a lousy job.
Exactly. I'm not growing. I'm not learning. I'm not flourishing. I'm not nurturing myself. I'm out of here.
And one of the several of the variables that I saw in the melanoma studies, because we did many studies, but that if somebody quit their job, and they had good reason for it. They didn't quit it because they couldn't do it or whatever. They just said, no, this is a terrible job. I'm not happy here. I want to do something else. Those were the unusual outcome people that Dr. Segabil was talking about. They might have had really bad um, prognosis in terms of the invasiveness of the tumor, the thickness of their tumor, and they did well. They quit their jobs, and all of a sudden, whew, burden lifted, and they did well. Some people got divorced.
You were talking about interventions that you perhaps looked at or developed with colleagues. Anything you could share about that? What kind of interventions did you look at? What works, what doesn't work?
Going over scripts of how, I mean, really basic examples with people. so that someone's in the hospital, you ask them, well, what's going on? And they are saying, well, I'm trying to get some sleep, but the nurses come in, they're doing their job, and they wake me up and they say it's time for this, and I question them more about this, and I finally get down to some level, because at some level there is a fantasy level about what's going on, and there's the reality of, well, the nurses are busy. Maybe if I object, something will happen. But with a lot of the type C, very strong type C people I've seen, they have this idea that, well, if I say something that this person doesn't want to hear, or that's critical of this person, they're going to sabotage my care. They're going to put something in my IV. I mean, they have very, it takes a long time to get to that level. And you say, whoa, did you just hear yourself say that? Whoa, do you really think? No, let's try, a way to communicate with your nurse so that, she doesn't feel criticized. Because a lot of the times what happens with the type C folks is they built up this resentment, like with forgiveness, whatever, and then it comes blurting out, "You're a terrible person. You keep doing this to me," and then it doesn't go well. No, that never goes well. So we go over a script. We say, well, first you start off with, complimenting the person and being constructive, and you say, well, I really appreciate your coming to visit me here in the hospital, and your caring about me is so appreciated. But I have to say that I'm feeling really tired right now, and if you could come back another day, or just the fact that you're here today means so much to me. Thank you very much, but I really need my sleep now. And then you practice these scripts for a number of situations, and people like that, giving them these scripts. So I do that a lot with people. How can you communicate your needs or your anger at somebody?
And I love that about what you're saying, because we're all different. We all are comfortable with some things and not comfortable with others. And I don't believe there is one specific wall and a specific ladder that can only be used for every circumstance. It depends on the person. And I believe that would be so loving, that would be, that they would appreciate it so much if you were to say, okay, well, let's practice saying this. Let's just,
right.
It's a small step, but it's in the right direction.
Right. And it has to be individually oriented, because, you can't just say, well, apply this in your life. No, you have to understand, well, what are the things that are bothering you right now that you wish you could, that would make you feel better. Well, too many visitors. Well, okay, let's practice that visitor script. let's practice some other script.
So these days, Lydia, how do you spend your time? Do you spend most of your time in research? Do you spend it in knowledge translation? Do you spend it in intervention? How do you divide your time? And where's the passion for you?
Well, to be completely honest, which I always try to be, I have so many interests. I have so many things that I'm doing.
Beautiful.
How have I been spending my time during the COVID pandemic, which was, that's a very specific thing. So I'm no longer, physically at the Institute of Human Virology in the University of Maryland School of Medicine, where I was a professor. But I correspond and talk with and communicate with, the director, Dr. Gallo, and with other colleagues there. And, I have a lot of communication. So I'm very interested in following HIV research. I'm very interested in following COVID research, scientific communication. We're talking about the problems that have been voiced with this current CDC director, who's a wonderful person, and she's very, very competent. However, she's been criticized, and I think to some degree rightly, even by the scientists, as having very unclear communications. And how can one do that better? So I've been, trying to communicate with people about how she could do that better. Now, how communication around COVID, about how long do you isolate? What kind of test do you get? Should you get testing? I'm very interested in those who have the misinformation about vaccines. Dr. Fauci is a personal hero of mine. I worked with him over the years, both on HIV and at NIH. And so that's one of the things I do. I also, as soon as things started to look a little bit better in June, I just said, well, I can do something. I'm a licensed clinical psychologist. The nursing home people are having a hard time. Let me go there. And I'm a consulting psychologist in a skilled nursing facility, which folks were really bad off. And so I was applying a lot of my psychological assessment acumen, because the folks might have cognitive impairment to some degree, and they might have physical impairment that complicates their emotional life, and so on. So, and of course, ending up in a skilled nursing facility where you can't see people is a very stressful thing. But I was doing that, and I've had to cut back on that. But the other thing I'm doing is I'm doing a huge amount of writing. Both a lot of the research that I've done on the scientific communications, as I was mentioning with COVID, and also I happen to have been one of the first women admitted to Yale College, way back when, and so there's been a book of narratives that was produced by all the first women who were still alive and still wanting to write their narratives, and I wrote a narrative for that. And so it's telling your story, and this book was produced, and at some point the editors chose to, for some reason, make the public book. They wanted to anonymize the authors, and I said, wait, you're denying my agency as the author of my story? This is not okay. So I spent a year gathering together like-minded women, first women also at Yale, and also our co-education partners, the men who were in our classes. And they said, no, that's not right. That's not right. So we got 418 signatures. We had a letter, and we finally got them to destroy the anonymous book and to produce a book which has people's names. If you want to be anonymous, well, choose it, but don't not impose anonymity on me, because that's part of owning who I am. I'm owning my story. So I felt that was an important thing for me to do. was to do that thing. And that's, so you asked me how I'm spending my time. Well, that's what
It's a powerful thing to reclaim one's voice, for sure. That's absolutely wonderful. Tell me, if there was what are you taking from your own research? How do you let any of the research that you've done, the interviews, that whole life journey, how do you let that inform you, who you are and moving forward? Tell us a little bit about that.
Whoa.
Share that wisdom,
Well,
if you may.
I just did a little bit by saying
Yes,
that
you did.
I chose to take on this. People say, well, okay, the first women in Yale. I mean, it's a tiny little group of elite people who had their thing. Well, it was important to me, and that was important to those other women, and I felt good about that. We had a victory. It was not done in a negative way. We had, we negotiated with the people who were editing that. And
it's important to speak up. It's important to speak up, to speak your truth, to claim your truth.
Exactly.
Yeah. In a non-aggressive way, but in a clear, well-articulated, authentic, kind, compassionate, but clear nonetheless way.
Right. And I had to be a little stronger than I would have preferred. And we all did, because there was resistance. They said, well, we've already produced the anonymous book. No, excuse me, you can't do that. That's called stealing my intellectual property. And no, you can't do that. So I had to be stronger than I would have. But I started off by saying, well, the first book you produced, the private copy for everybody, that was wonderful. It looked really good. We want you to edit the other version, which has the author's names and anonymous if they chose to be. We want you to do that. However, I want to have my name on it, and so do these other people. So we insist on that. So I did follow my own advice a little bit there. I have a kind of unconventional life. I have my friends.
And you're raising llamas.
I have llamas. I have and people would say, oh, why aren't you on the board of a company? Why aren't you doing this? And I go, no, this is what I want to do. I'm on a farm. I'm on a farm. It's a 5.5 acre farm. There used to be cows on it. I don't like cows. Cows are smelly. Llamas are beautiful. Llamas are elegant. I'm going to have llamas. And so people go, oh, you're nuts, Lydia. But I have my llamas and I have my rescue dogs and my rescue cats.
That's so beautiful. Well, Lydia, thank you so much for sharing your wisdom and your knowledge with us today. I so much enjoyed this interview. I've learned so much from you today. And I'm sure our listeners will be very appreciative of all the knowledge and the wisdom that you shared with us today. Thank you for that.
Well, I appreciate all your questions because they were right on in terms of trying to draw out some of the main points that may be more relevant today.
And this concludes my interview with Dr. Lydia Temoshok. Thanks for listening. Until next time, be well and take care of yourself.